Hi, my name is Ana Belén Zúñiga and I'm going to talk about glucocorticoid induced osteoporosis. Glucocorticoid induced osteoporosis is the most common form of secondary osteoporosis. Fractures, which are often asymptomatic, may occur in as many as 30 to 50% of patients receiving chronic glucocorticoid therapy. Vertebral fractures occur early after exposure to glucocorticoids at a time when bone mineral density declines rapidly.
Our next speaker is Dr. Ken Sag. Ken received his bachelor's degree at Michigan, his medical degree at Northwestern. He got a master's in science and epidemiology at Iowa. He was a resident at Northwestern, a fellow in rheumatology at Iowa, professor now at the Division of Clinical Immunology and Rheumatology at UAB. He's director of the CERTS at UAB and associate director of the UAB Center for Metabolic Bone Disease. He's won the Teacher of the Year Award. He's gotten the Max Cooper Research Award. He's been co-chair of the AMA Consortium on Osteoporosis Quality Measures. He's a member now of the FDA Arthritis Drugs Advisory Committee, co-chair of the ACR Quality Measures Subcommittee, Board of Trustees, National Osteoporosis Foundation. He's been the osteoporosis section editor for the Current Opinions in Rheumatology, osteoporosis section editor for Current Rheumatology Reports, and the editorial board of Arthritis Care and Research in the Archives of Internal Medicine. And this morning, he's going to talk about glucocorticoid-induced osteoporosis.
Thanks very much, David, and good morning. It's a great pleasure to be here and to see this wonderful course continuing to thrive, and to have an opportunity to talk about a topic of interest to all of us, since this is one of our favorite drugs. Despite all the great advances that have occurred in our field, we continue to rely heavily, for better and for worse, on glucocorticoids. Steve's talk was wonderful. It's always great to hear him speak and to hear some of the controversies in his very evidence-based but yet common-sense approach to how we take care of our patients. Here are my disclosures, and these are also contained in your handout. And I think it's always nice to start with the case, and this is my favorite case, and I'm sure one of your favorite cases too. Not favorite in that it's something you like to see happen, but favorite in terms of this being really the poster child for our problem. This is the older Caucasian woman who you diagnosed with temporal arteritis and appropriately start on high-dose glucocorticoids, and she develops the very, very predictable complication of compression fractures of her spine within the course of a year. So this is what we're trying to prevent. This case occurred at a time when our options were quite limited. But it's not just this patient that we worry about. Here's the guy who I saw at the Iowa City Veterans Hospital who was referred to rule out rheumatoid arthritis, but had one of the worst looking spines of a man his age and had been on 10 milligrams a day of prednisone for the past 10 years for management of his COPD. And here's one of our younger-ish lupus patients who
Applications in medicine. Fractures tend to occur at higher MBD levels than in women with postmenopausal osteoporosis. In human subjects, the early rapid decline in BMD is followed by a slower progressive decline in BMD. Glucocorticoids have direct and indirect effects on the skeleton. The primary effects are on osteoblasts and osteocytes.
Osteoclasts and their precursor cells are regulated by different signaling pathways and molecules. One key regulatory molecule is the protein rank ligand, which is produced by a variety of cell types, including osteoblasts and their precursor cells. This protein has been shown to exert its effects on osteoclasts and their precursors through an interaction with the cell surface receptor, rank. The interaction between rank ligand and its receptor, rank, triggers the activation of signaling pathways, which are involved in the differentiation, activation, and survival of osteoclasts. Such signaling pathways can trigger the fusion of precursor cells to form mature multinucleated osteoclasts. On these mature cells, rank ligand can interact with its receptor, promoting osteoclast activity and survival, leading to increased resorption of bone. To balance the effect of rank ligand, osteoprotegerin, or OPG, is secreted from osteoblasts. This protein acts like a decoy in binding to rank ligand, preventing rank ligand from interacting with and activating its receptor on the surface of osteoclasts. Various hormones and cytokines modulate the balance between rank ligand and OPG. For example, parathyroid hormone stimulates the production of rank ligand while at the same time repressing the expression of OPG, an effect thought to increase the activity of osteoclasts. Conversely, estrogen can increase the expression of OPG and inhibits rank ligand signaling. These changes, which are thought to reduce the activity of osteoclasts, may contribute to estrogen's ability to preserve or increase skeletal mass.
Pros and cons. Glucocorticoids impair the replication, differentiation, and function of osteoclasts and induce the apoptosis of mature osteoblasts and osteocytes. These effects lead to a suppression of bone formation, a central feature in the pathogenesis of GIO. Glucocorticoids also favor osteoclastogenesis and, as a consequence, increase bone resorption. Issues applying Ecuador. Studies in tissue and organ culture suggest that glucocorticoids have a direct effect on bone, causing inhibition of bone formation and enhancing bone resorption. Glucocorticoids decrease calcium absorption from the intestine and increase renal excretion.
So the best way to diagnose osteoporosis or osteopenia is with a DEXA scan. That's something that either your orthopedic surgeon or your family practice physician can order for you. And basically a DEXA scan is the most reliable way with the least amount of radiation to measure your bone density. So it takes different images of your spine and your hip and kind of compares that against the bone density in a normal 25-year-old. And it gives you something called a T-score. So your T-score will put you on that spectrum of the osteoporosis or osteopenia. So if you're taking that and you get a T-score between 1 and 2.5, which measures the standard deviation of your bone density compared to that normal person, that puts you in that range of osteopenia. If it's anything less than 2.5 standard deviations below a normal bone density, then you're in that category of osteoporosis, and that's when you should really be started on some sort of treatment or therapy for it.
Conclusions. Osteoporosis is common in patients requiring long-term treatment with glucocorticoids. Careful attention to preventive management may minimize the severity of this serious complication.
नमस्कार फ्रेंड्स, स्वागत है आपका आपके ही अपने चैनल में जिसका नाम है फार्मेसी डिक्शनरी। आज हम जिस वर्ड को देखने समझने और उसके बारे में दो तीन चीजें नई ऐड करने वाले हैं, ये है हमारा ऑस्टियोपोरोसिस। व्हाट इज द मीनिंग ऑफ ऑस्टियोपोरोसिस? यहां भी हम इस कटिंग रूल को अपना सकते हैं। ऑस्टियो डिपेंड्स करता है, रिप्रेजेंट करता है आपके बोन को, और पोरोसिस कहने का मतलब है एक